Morning, everyone. We'll be presenting a case on locally advanced NSCLC. A 65-year-old male came to us who was a cigarette smoker, 40 pack years, who has reformed since 1 month. He did not have any comorbidities, no past surgical histories, or any history of TB or COVID 19 in the past, and he did not have any family history of malignancy. He came with chief complaints of dry cough since 6 months, unexplained weight loss of 10 kgs over the past 6 months, and right sided chest pain since 1 month. On inquiry, there was no history of fever, no history of shortness of breath, no history of hemoptysis, no complaints of change in voice, no history of noisy breathing, no history of dysphagia, no complaints of severe radiating pain in the right upper limb, no complaints of drooping eyelids or decreased sweating over the face. He further had no complaints of headache, any seizures, nausea, or vomiting, and there were no complaints of backache or any other bony pain. The patient was examined in a well-lit room with prior verbal consent taken. He was ECOG 1, effort tolerance was 3 flight of stairs. His height was 1.59 meters with a weight of 42 and a BMI of 16.6. There was no palpable supraclavicular lymph node, no clubbing, no facial swelling or dilated neck veins or neck swelling or supraclavicular fossa fullness. No accessory muscles of respiration was being used. Trachea was central, and on auscultation there was decreased air entry in the right upper zone. On summary, he is a 65-year-old male, cigarette smoker, 40 pack years, complains of dry cough, weight loss, and chest pain, with no supraclavicular lymph node and decreased air entry in the right upper zone on auscultation. So, my differential diagnosis will be a malignancy as the first one and tuberculosis.
So, is he a worker? What place is he working? That also matters. So, what is professionally, what is he doing?
Ma'am, he was a farmer from West Bengal.
So, any exposure to any sort of fumes or something like that, which also makes a difference, because we have diseases where we have occupation based, where the patient comes up with these features. So, that is also very important. What place does he come from? Is he exposed to some, factory or something like that, where such fumes or something he's been exposed to?
Or so he did not have any history like that, ma'am. No history of any exposure to fumes or any smoke. Other than smoking, there was no positive history, ma'am.
So the weight loss, do you consider it to be a significant weight loss? The BMI is only 16.6 for this patient. So was he a thin-built patient, or
he was a thin-built patient, sir. So he was having more than 10% weight loss over the past 6 months. So I'll consider it to be a significant history.
Does it also indicate the volume of tumor, if at all you are going with a diagnosis of cancer? The disease burden?
So weight loss will indicate a greater volume of disease. Also, it will point towards a later stage of the disease, sir. I'll be expecting a stage 3 or a stage 4 disease in that case.
Who is the radiation oncologist here? Acha. Our RTOG protocol were in concurrent CTRT, low dose, standard dose and high dose. Weight loss 10 kg. What is the, you remember the month they have specified? Here he is talking on 6 months. There, one of the points where patient becomes unfit if particular weight loss is there. They didn't put it for 6 months, they put it for about a month at that time. So it's one of the small differences we have to remember when we take up a protocol. This is what do they specify, how do we take it up?
We have conditions like asbestosis, we have conditions like mesothelioma. So yes, the first diagnosis that you clinch is yes, tuberculosis and malignancy, but there are certain other benign sarcoidosis, but there are other benign conditions as well that has always to be kept in differential diagnosis, because once when you start ruling out,
The patient came to us with a NCCT thorax done outside in March 24, which showed a right apical segment mass of 4.6 by 3.2 centimeters and emphysematous changes in the bilateral upper lobes, and there was no effusion. So at our center, we have done the following evaluation. We did a CT-guided biopsy of the lung mass. We did a PET CCT, MRI brain to complete staging, and medicinal staging was done by E-bus. So this is the biopsy video. So the biopsy was a poorly differentiated squamous cell carcinoma, P40 positive, negative for TTF1 and synaptophysin. The PET CCT. This is the lung window. So on PET scan, he had a 5 centimeter mass in the right upper lobe, SUV max of 12.84 with no bony erosion reported. There was a low FDG uptake in the right hilar node, SUV max of 4.33, and there was no effusion, ipsilateral or contralateral lung nodules or distant mets. The MRI brain had no evidence of neuroparenchymal metastasis. So the patient underwent functional evaluation to see for fitness for surgery. His FEV1 was 78% with a 4% bronchodilator reversibility. DLCO was 75%. A post-op predictive value for a right upper lobectomy at that time was FEV1 65.6 and DLCO 63.1. His 2D echo did not show any major abnormalities, and his 6-minute walk test was 420 meters without any desaturation. An EBUS was performed. Level 2L, 4L, 4R and 7 all were sampled and were negative for metastasis. So my clinical diagnosis is a poorly differentiated squamous cell carcinoma of the right upper lobe, stage 3 T3N1M03A as per AJCC 8th edition, the probable etiology being smoking.
So you did a EBUS. So this is just a simple question. When do we do a EBUS and when do we have to complement it with the EUS? What are the stations which is can be demarcated by EBUS, and where is the indication when your surgeon will ask why didn't you get a EUS done?
So EUS will, in addition, EBUS will help us sample upper paratracheal, lower paratracheal, subcarinal and hilar nodes. We can also sample level 11 also. But EUS will help us sample level 8 and level 9, paraesophageal and the inferior pulmonary ligament node, in addition to the EBUS nodes.
Is it that every time EBUS has to have a EUS, or there are indications where I need to get a EUS done?
Every time at our center we are not doing a EUS. So in case of lower lobe primaries, and in case of suspected nodes on my clinical staging with a PET, I will do a EUS. Otherwise, I will not attempt a EUS in all cases.
So PET will give you some guidelines regarding whether we should do or whether we should not do. Now your hilar lymph node had a SUV of 4.3. Now how confident are you labeling it as a N1? You said N1. Because the primary had a SUV of 12.33 and this had a SUV of 4.3, which is a borderline sort of. And an Indian scenario where your differential diagnosis was tuberculosis. So how well are you confident labeling it as N1? Can that be N0 even, because that is a very small size hilar nodes you have?
It can be N0, ma'am. It can be N0 also.
It could be N0?
It could be.
So this was what I just wanted to emphasize. At times it is very difficult in our scenario also, because the I mean, the PET scan people, they also are not very confident whether to label it as malignant. They say the chances of metastasis cannot be ruled out. So this is the language that what they use.
Can you, if it is EBUS is negative and PET you are suspecting of positivity, what further test can you go for to confirm your PET finding?
EBUS if negative, sir, we can go ahead with an invasive mediastinoscopy.
Good.
So anybody from the surgical side? Yeah. So how do you read the imaging? You think it is operable? So it is.
So operability was a concern because the tumor was very closely adherent to the chest wall and patient was having right-sided pain. So
Right.
this patient underwent further evaluation with the MRI thorax to see for intraspinous extension, which was negative. So that's why we had gone ahead with surgery with this
So,
patient.
but you can clearly see that it is stuck to the vertebral part and it is to the lower, the posterior thoracic wall. Would you like to call it a superior sulcus tumor?
So he was not having, clinically he was not having symptoms of brachial plexus involvement. So we were not suspecting a superior sulcus tumor at this point of time. Seeing the images also, sir.
Yeah. Did PET scan influence your decision to not to do a mediastinoscopy?
The patient underwent a mediastinoscopy, sir.
Okay, so that detail is
Yeah.
not mentioned here. So
He underwent a mediastinoscopy, but the mediastinoscopy was done during the definitive surgery, just before the definitive surgery.
right. So you're not discounting a mediastinoscopy
Yes.
here.
Yes, sir.
So when will you be comfortable, just like be happy with EBUS and US combination, provided both the facilities are available, and let go of mediastinoscopy? Just a theoretical question, not connected to this case.
If my EBUS is giving me a multi-station N2, then I will not go ahead with a mediastinoscopy. I will plan for a non-surgical management for the patient first.
It is for the positivity which will actually rule out an additional investigation than for the negative result. Negative result will probably still mandate a mediastinoscopy.
Yes, sir.
But still, whether it is operable, you did not answer the question. You said there is a chest wall involvement which was ruled out by MRI. So what is your impression?
So operability was ruled out, was confirmed initially with the functional evaluation. Resectability was ruled out with the MRI.
Yeah. So
we
in
went
case
ahead
like
with
you are
surgery.
going ahead with surgery, but so what is running in your mind? Whether you want to do it upfront or whether you are going to give some neoadjuvant treatment and then you are going to operate. So what is running in your mind? You are not looking at the PFTs. You are not looking at the MRI. So what is running in your mind?
So considering it is a T3 N1, as we have labeled him as a stage 3A, so that made him a locally advanced case. But there is no role for neoadjuvant chemotherapy to downstage a T3. So we, if at all we were expecting a R0 at the end of our resection, we went ahead with surgeries.
You will be taking the case directly more or less to surgery, or you will be discussing this. For example, you are having a patient is going to ask you what are the chances for me, if you do a surgery, what are the chances of me to survive 5 years? Simple thing. Will you answer it? And at the same time, will you ask the medical oncologist, the radiation oncologist also to give the percentage chances? How is it generally practiced?
So this case definitely should be discussed in a multidisciplinary team because of two reasons. One thing is that we were still questionable about the resectability, and if at all chest wall involvement was proven with a N1 node, then patient could have benefited with the NACT in that case.
Actually, what is the percentage you are going to probably, this is the probable percentage of your living, what you are going to tell to the patient. If I am doing a surgery and if there is no adjuvant treatment needed, possibilities. He is going to ask you, you are going to do a surgery. I hope I am going to live after the surgery, there is no immediate complication. Fine, I am ready. Should I undergo that major procedure or I am happy with a non-invasive procedure? Non-invasive, you will be telling. I am asking, non-invasive or invasive, what should I go? Is it better for me? Definitely it is better, I have no doubt about it. I just want to tell the audience what is the chances like.
So I'm not aware of that percentage.
Suppose sir says if you go for CTRT upfront rather than going for surgery, which is better and why? With what data you have? Non-operative versus operative. Sir just means to say.
Definitive. So as far as giving a neoadjuvant NACT-RT, there is a data by Pless et al. So which showed that NACT-RT is a viable option and which can be followed up by a surgery.
From
So-
RT team, if anybody wants to give some opinion, you can also add on to this.
So if we are going for definitive CTRT for this patient, then we are looking at a 5-year survival, which is be more than like on the upside of 30%. And so like that is the prognosis from like if we undergo CTRT, and surgery would also be, I hope it will be around the same, only 5.
But you are giving adjuvant in this case, no? Suppose
Yeah.
you are operating, stage 3, you will be giving adjuvant.
Yes.
Then what will be the survival data then?
The control arm in Pacific had median OS of around 30 months, and with adding durvalumab, it was median OS was around 40 months.
So we have not tested rather what we have to give, because we have enough discussion about if we give one, whether we should or not. Even if we have to give adjuvant, because anything more than stage 1 you have to give adjuvant. I mean, you have to give adjuvant therapy post-surgery also. So sir says, if I'm not going for an operative procedure, it's a T3, an operable lung case, CTRT versus surgery, what the difference will be between the survival. This is for the house, for the students. The superiority of the surgery you have to show here.
Again, we are earlier, for example, somewhere around 10 years ago, this same stage 3 only with RT has been somewhere around 15 to 20%. With the addition of your carbopactly, it has come out to somewhere around 28 to 30%. 5 years you are talking. Okay, no? That's a good improvement we have got. Good addition. In this, compared to surgery alone, suppose you want to do surgery plus adjuvant, what it will be like? Patient will be happy today with 30% survival 5-year chances, or he'll be happier with your option.
Let me ask this in a simple way. If your patient undergoes surgery followed by adjuvant chemotherapy, what will be the outcome you will be telling your patient versus CTRT, which we already now know that it is going to be around 30%, or with durvalumab around 40% 5 years. So what are you going to tell your patients with surgery and adjuvant therapy? What are your outcomes going to be over next 5 years?
With R0 resection achieved with adjuvant chemotherapy and radiotherapy, I will offer him there's a range, so it's around 30 to 60% survival, overall survival.
Definitely about 1.5 times at least, not exactly double, but it is much, much superior. So that is what you are going to give some percentages to the patient. If there is not, in the private practice, much of us do not do a separate groups. For example, there is no lung tumor group, there is no head and neck tumor group, whereas in setups like Tata Institute, you have got groups. So you should be able to tell the patient with confidence, this is the data of world, this is the data of TMH, so I will be offering surgery to you as the first choice. If you have a worry, if you do not want it, talk to me, concurrent groups of radiation oncologists and chemotherapists.
So,
So only if the patient has any comorbid condition, the patient is not fit to be operated upon, anything stage 3A which can be resected should be offered surgery. So that is the message to the house. You cannot compromise it unless the patient is elderly and lot of comorbidity, your pulmonary function test or something that didn't permit you to operate. Then the choice goes that we have a compromised treatment with CTRT.
So can you just go back to the PFTs? What do you make out of this? So what is your impression about this PFT?
So sir, any post-op predictive value for a particular lobectomy or pneumonectomy, as we see it, FEV1 and DLCO more than 60% will put him at low risk according to the American College of Chest Physicians. So we can go ahead with surgery for this case. If any compromise would have been there, FEV1 DLCO ranging 30 to 60% or less than 30%, he would need to be evaluated further with cardiopulmonary exercise testing.
Let us just see the first two lines. So the FEV1 and DLCO, are they matching or they discordant?
They are matching 78. FEV1 and DLCO, sir, both are reduced in this case. So it is showing some pattern of obstructive and restrictive pattern.
Okay. So, what do you think? Like, if there is some mismatch in FEV1 and DLCO, what do you make out of it? Like, does it affect your decision of surgery or non-surgical treatment? What do you make out of it? What if your DLCO is very less compared to your FEV1? You are very happy with FEV1, but not really happy with DLCO.
So that would mean that the oxygen exchange of the patient is also being affected. So I would need to further evaluate that with a ventilation perfusion scan, if possible.
Yeah. So essentially, it indicates that there is an interstitial lung disease of whatever reason, either a severe emphysema or interstitial ILDs. And the 6-minute walk test is not very great. It is just like 420 meters. So overall, I feel it is not a great picture, meaning like you will be super confident. So you want to evaluate it further, or you are happy with this?
So this patient was not evaluated further. We were happy with the numbers at this point of time.
So hypothetical, I don't know what happened later. So you take him for surgery because it is N1, mediastinoscopy is negative, and you see that it is very difficult to release it from the vertebral part. What do you want to do? Call it inoperable, or still go for an R0 resection?
We'd still like to go for a R0 resection, and if at all it was still stuck to the pleura, we could have done an extrapleural dissection, and en-bloc resection of ribs is also possible in this case. So if at all en-bloc resection is done along with the resection of the primary, then the patient will have a good survival.
So just I'll add one more variable. Same findings, but you have a single station N2 on mediastinoscopy. What you will do? You'll still go ahead with surgery, or you'll back out and think of something else?
Single station N2, sir, if at all it is not a bulky node, I'll still go ahead with surgery. I will not back out. But I will like to do complete mediastinal lymph node dissection in that case.
Proceed. Anything from the audience till now?
So just a note on mediastinoscopy. So why was the mediastinoscopy done for this patient after having an EBUS negative?
So there is a trial, ASTER trial, which is proving that the sensitivity of mediastinoscopy added to EBUS is more than EBUS or mediastinoscopy itself. So in our center, we are following the protocol. If at all EBUS is negative, we are going ahead with the mediastinoscopy as well.
So at
But the guidelines are, if the PET is discordant with your EBUS, then only mediastinoscopy is indicated. Because PET shows the disease and your EBUS is negative, then it's the indication that mediastinoscopy should not be a complementary, even if in all cases, what's the advantage of getting a EBUS done then? So that is the essence where you are trying to not going for any invasive procedure. So if the PET is discordant, then that is perhaps a situation where I should go for mediastinoscopy.
So actually this debate of doing a routine mediastinoscopy has ended after the RCT published in JCO in 2023. So there's a very good randomized control trial for the interest of students. So if EBUS is negative, we stop doing mediastinoscopies. So this is, the era, institutes, even in TMH, we routinely used to do mediastinoscopies in spite of EBUS being negative. But now if EBUS is negative, mediastinoscopies are completely avoided. And
but if you see the guidelines, it says that if the PET is discordant, PET has a lesion showing a node, and then EBUS is negative, then in that very situation, even if the EBUS is negative, that should be complemented with mediastinoscopy. This is what the NCCN says.
Yeah, but that's been proven in the randomized control trial. So that's the MEDIAS trial which has actually come up. This is for the sake of the residents, so I think they should go back and read, because the indications for mediastinoscopy is coming down. So pre-2023, yes, I completely agree with your statement that every patient we used to, because 30%, even the STMH data which actually shows 30% we were actually missing, and very confusing between those which came as granulomatous had an element of malignancy in those group of patients. So I think when we have data, that's something that which we should. So just for the interest, I think you should all go back and read the MEDIAS trial which was published in JCO. It's actually very good. So I think even TMH is routinely, not for all cases. It's not routine to do for all cases, even in TMH now is what my understanding is.
So now we have a T3N1 ready for the treatment. You as a surgeon, you decided yes, what will you do further? The surgery, next.
So, because the tumor is resectable, I will plan for a multimodal video assisted thoracoscopic surgery. If possible, that will give me an advantage that the patient will have less post-operative pain and early recovery.
So the kind of imaging, will you still be open to have a low threshold for conversion to open in case you find it difficult?
Yes, sir, definitely.
You're going for uniportal VATs?
No, sir, multiportal VATs. Uniportal VATs would not give me good access in this case.
So can you tell us about the arrangement of surgery quickly, how you want to go about it?
So, sir, the patient will be taken under epidural and general anesthesia. Epidural is just in case the patient has to undergo open surgery. He'll be positioned in the left lateral position, considering this is a right-sided tumor. Patient will have a double lumen tube inserted for right lung collapse, and we'll put the multiportal ports as the standard ports are expected, and then the surgery will be attempted. So.
Yeah, proceed further. Like, will
for the medical oncologist on the team, do you want to give neoadjuvant chemotherapy or immunotherapy in this patient?
Yes, we can do PD-L1 testing.
No, do you want to give chemo immunotherapy?
Since it is adherent to the chest wall, we can give immunotherapy so that.
You should have told him before he was going to say that I am going to do this surgery now.
So we can have a decrease in the tumor size that will give a better resection.
It should. The point is, it should be a multidisciplinary team approach, discussion, and then go ahead with surgery.
So, do you want to give chemotherapy, immuno alone, or immuno in combination with chemotherapy? IO plus chemo or only?
Chemo plus IO.
How many cycles?
4 cycles followed by response assessment.
And then, how long would you want the surgeons to wait?
If it is, if they can go ahead with surgery.
But immuno has some. So you want the surgeon to wait for you to give 4 cycles of chemo plus immuno. When the surgeon says that he is confident doing a ART0 resection for a stage 3A cancer, how do we justify that?
So, no, if they are confident enough to go ahead with the ART0 resection, I think we'll go ahead with the surgeon, because if after chemotherapy and immunotherapy, if there is toxicities and it can lead to delay in the definitive surgery. So
that is the main thing. If the surgeon is confident, it's stage 3A, operable, resectable disease, I don't think we should wait the surgeons to, get the things from going.
You got further slides, or we'll go ahead with the math?
That's it.
No further slides.
No further slides.
Okay. Now, you as a radiation oncologist for the group, tell us, the surgeon decided no, the patient decided no. You wanted to go ahead with a non-invasive treatment. What do you like to do? And make us clear. What is take 2 minutes, make us clear.
So, if the patient is not being taken up for surgery, and if it is coming for definite chemoradiotherapy, so now since surgery is not there, so treatment plan would be definitive chemoradiotherapy. But before that, so all the pre-functional assessment has already been done, pretty good. So the plan would be to irradiate the primary tumor along with the involved node. So in this case, the hilar node was involved. So and to a dose of 60 gray.
Very good. The first point you made was, one is the primary side along with the involved nodes. This is the first major point. Next one.
So the planned dose would be 60 gray in 30 fractions at 2 gray per fraction.
Perfectly okay. 60 gray in 30 fractions was 6 weeks. Yes. And what is generally the volumes you think, doctor? If the tumor is, whatever the tumor you say, we call that as a gross tumor volume. Whatever you mark it as a gross tumor volume.
Yes.
What is the margins you will give for a clinical target volume for a squamous cell carcinoma?
So, so I will take a clinical additional margin of 5 millimeters for.
In general, remember the rule like this: squamous is 6, S for S. Adeno or non-squamous is 7 mm. Margins generally given the rule is whatever the GTV you see, margins for microscopic is 6 for squamous and non-squamous is around 7. Okay, continue. So that is the volume you are getting.
Yeah.
Beyond that, what other volume you are going to make?
Another planning target volume.
Planning target volume. To get the planning
millimeters.
target volume, do you any different ways of treatment? Your simple one is you are talking is a standard 3D conformal radiation. Next to that improvement in that is?
So
intensity.
Yeah.
You are not getting the question. Intensity modulated.
Yes.
Something beyond this because the moving target is there.
So
what do you like to do?
So to encompass, to account for the motion of the target.
Motion.
Yeah.
You accept the motion and you arrange for a planning like a
Yes.
4D planning. Okay.
Yes.
Then come to the doses now.
So doses will be like 60 gray in 30 fractions.
16, 30 gram. As of today, the accepted standard because beyond that we have not seen a change. The standard RTOG 0617 did not give us.
Yes.
Is it because of the dose problem or some other problem happened in that? Because we got at least more than 10 major papers from that, lot of sub-analysis.
So another concern would be the increased toxicity that would be coming when we are giving higher doses, so which would affect the outcome, like esophagitis, mainly the esophagitis, which would affect the outcome of the patient, like it can bring down the survival, the toxicity.
Yes, agreed. Esophagitis maximum dose is one of the points, yes. Major things which has come out recently, in the last 2-3 years, sub-analysis. 60 and 70 doesn't matter. It is more related to the base of the heart and the V40. Yes. The volume getting 40% of the dose, that is an important thing which has come up. That decides the survival rather than the doses of 60 or 70. That's very important. Kindly go through this, very important. The doses to the base of the heart, we are talking where the root of the aorta, where SI node is there, anterior descending artery is taking its origin, AV node is coming nearby. This structure, they want it to be as minimal as possible, somewhere around 9 gray or less, if we are able to achieve it. So this is an important thing for you people, for the radiation oncologists here. Dose to the heart, various substructures, V20, V40, LAD doses, mean heart doses, everything matters a lot in addition to esophagitis. Okay. Yeah, any other points in radiation you want to say? The survival you said is somewhere around?
So it will be upside of 30%.
30% easily, that's not a problem.
Yes.
So your survival, you say, if you are getting an R0, will be superior. I agree. So you should be able to tell some good study and the patient to the data. This study, one of the major study, gives this point. 0617 RTOG gives somewhere around 28-29% in that range. Like that, you should be able to talk to the patient if you are in the lung group. Okay?
And concurrent chemotherapy should also.
Yes. You get that.
What chemotherapy? Do you want to give concurrent chemotherapy or chemo radiation sequential or no chemotherapy or what? Medical oncologist.
Concurrent.
Yeah. So what chemotherapy? What dose? Why?
Platinum based cisplatin with weekly dose.
Why not 3 weekly?
Yeah.
Giving 100 milligram is not a good option, but then why?
Toxicity.
What will we prefer for this patient? He has a good
Elderly
performance status.
patient.
Yes, we have to categorize the patient. Yes. This is basically the theme, but otherwise there are certain institution which follows a 100 milligram. What is the rationale behind using 100 milligram per meter square? There should be some rationale.
Because only 3 doses we can complete. I mean, 200.
Because when you're using a higher doses, yes, perhaps this will contribute not only as a radio sensitizer,
okay,
but it can provide also as a systemic effect on this disease. So is it a theoretical case or do we have a histopathology of what you did? So is what this is what operated?
So intraoperatively, ma'am, the patient.
What was the final pathological result? We just wanted, because you said the vertebra was involved, so I just wanted to know.
Final histopathology was PT3N0M0. PT3N0. So ma'am, the margins, so it was a very difficult tumor to resect intraoperatively, so we had to revise the margin, and the revised margin had also come positive, so we've labeled it as a R1 resection, and we've sent the patient for a post-op radiotherapy.
My colleague just made an important point about something beyond the photon therapy. You are Srinivas? Srinivas is there? Chilikuri, yes, you tell, or anything beyond photon therapy? I do send cases at times to somewhere else.
You're asking about proton.
Yes.
So as of now, the standard is photon therapy. With protons, we'll be able to achieve a better dosimetry, but clinical translation of it is.
Yes, this is important again thing coming up. The biggest difference is protons and photons, both are ionizing radiation. Both have got the same nearly biological equality as far as the cell death is concerned. But the biggest advantages for proton we have is rapid reduction in the depth doses. That is fast reduction in the dosage of surrounding structures. In a personal capacity where we have seen, I have seen a cases where in say a lung, we tell the patient, sometimes it does become a little problematic when we see the patient. We tell them, we have to do a plan. If the heart dose exceeds the tolerance, I will not be able to take you up for a treatment. You have to go to some other center for proton therapy. We have seen cases, two patients are living beyond 4 years, excellent life. Proton does gives an advantage. So there are cases which may be suitable for a proton, but in general, this can be decided only when you do a plan. After you complete that planning scan, you do the plan, then only you make the step. Unless and until you are very clear in the day one itself, large mass, very close literally to the heart, you can go ahead with that. Otherwise, masses wherein you feel may not be worthwhile for you to do a plan, photon therapy plan, and if it is coming within the accepted heart dose limits, you can do. If not, worthwhile for us to refer to a proton facility, which is a particle therapy. Okay.
With this we conclude, but then this patient was operated upon. He said the margin was positive, reoperated, again it was positive, and then the patient had to be sent for CTRT. So perhaps, did you discuss with the multidisciplinary board whether we should have given neoadjuvant in this case in the form of chemo, immuno, something like that?
Retrospectively thinking, it would have been a good call.
Yes. So this is very important that every patient, should be discussed in MTD. With this, I think we should.
Just curious, did you just go ahead with a VATS resection, or finally it was converted?
We completed the entire resection with multimodal VATS.
Multimodal VATS. And was it just a lung resection, or did you involve
we had to remove the pleura, sir. So we did extrapleural dissection at the apex.
So no vertebrae or
no
ribs?
vertebra or no ribs.
I have a doubt. When we have a patient stage 3A, and since we have trials coming up in all the subgroups of perioperative, neoadjuvant, surgery followed by adjuvant, then how do we interpret the results with the cross trial, like when we compare all the trials, how do we actually come to a management to a patient which is 3A and upfront resectable? Then we have to take in one line, either we go for neoadjuvant, or we go for perioperative, or we go for surgery followed by adjuvant. So how do we actually make a decision when we are sitting in a clinic?
I think it has an individualized, and every patient is different. We just cannot generalize things, what I feel. So perhaps this patient where I think somebody said vertebra was involved, so perhaps if we could have given a preoperative some in the form of therapy, margins could have continued.
Like ma'am, for example, he's a surgeon and he evaluated and he felt the patient was upfront resectable and he was confident enough to do a R0 resection. Only retrospectively they found out intra-op that it was involved, and because initially MRI they thought that it is not involved. So at that
so
even in the
with the best of the MTD, with the best of the tumor board decision, there are cases which are going to land up like this. That we thought it would come to be an R0, but it came with the margins positive. So there cannot be 100% for everything, but for majority of the cases where you think your radiation and your medical colleagues sit together, things can be sorted out. But even for the best of the best, what you said in the tumor board decision, it was said resectable, but still the margins came positive. There has to be a situation, and then CTRT people, they are going to help you out. They are going to radiate you.
Why can't we upfront go for the neoadjuvant?
In all cases, it's not the guidelines. So as you know,
in
what
3A
we discussed,
it is approved by FDA.
up till 3A, the choice is going for upfront surgery gives you a better survival, more than 1.5 times what can be given by CTRT alone. So that why the reason CTRT is reserved only for the patient who cannot go for upfront surgery for comorbidity or any such.
Ma'am, my doubt is, if a patient is coming up, since I already have the data for neoadjuvant chemo-RT in a setting of 3A, then why not we directly go for it and give a benefit of doubt instead of going for surgery and then retrospectively thinking that we should have gone for it. Why
Yeah.
don't we follow it?
Yeah. So
I completely agree with your point. So, and another quick comment on the randomized data, whatever is available. See, the data is always in controlled condition. You have to understand that. So, selected patients in good performance status and in extremely controlled conditions, because that's how the trials are conducted. But in clinical scenario, most of the things are not in your control. You have to factor in the morbidity, financial status, logistics, everything, and then you take a decision. But that doesn't mean an inferior outcome.
So answering your question is, you're right. Now we have data that is evolving for resectable. So we are not talking about, this might be the borderline case which could have been borderline resectable. But if it's a resectable cancer, there is definite evidence. Dr. Monica had presented all those trials, Checkmate 816 with Pembro, where stage 1B more than 4 centimeters up to 3A resectable tumors. We are not accepted it because the data is new and it's evolving, but probably in the future it could be in the standard guidelines. Data is there for nivolumab where you have better event-free survival, better PAT-CR, and no worsening in the time to surgery or no big dropout in the patients who went for surgery. So what you're saying is correct, that we are not using it in routine practice yet because it's evolving data. The criticisms of these trials are we don't have long-term follow-up, which will come in time. So probably in the future we may not have a scenario like this where a 3A is taken up for surgery. It might be like esophagus, we are going to offer some kind of neoadjuvant and then move on. So you're right in that.
So because of limitation of time now, we'll move on to
I'll just make a quick comment, and the question is quite valid actually.
Yeah.
And what we want to do is, because the residents are also there, we can take the guidance from the biomarker testing. In a patient with a resectable 3A disease, if the biomarker is showing EGFR positive, you will not offer any neoadjuvant treatment, any preoperative treatment, will go for direct for surgery. And if the patient is having a PD-L1 percentage of more than 50%, we have a confidence in using adjuvant atezolizumab. And also have a confidence in using neoadjuvant perioperative keynote trials, where Win 671 has shown a overall survival benefit. You look for trials with overall survival benefit. IM Power 010 has a adjuvant atezolizumab with overall survival benefit. If PD-L1 is more than 50%. If PD-L1 is less than 50%, you have a choice of using the pembrolizumab. And if the EGFR or ALK is positive, you probably don't go for any neoadjuvant treatment, something like that.
So maybe in next lung masterclass or after that, our medical oncologist will have better to fight to say that we will give something even if it is resectable. But
so from a surgeon's perspective, if you are going to get an R0 resection, then only attempt. Okay, that is something that which I would put down. It might be EGFR positive, but if I'm going to get, even if there is the slightest possibility that I'm going to have an R1 resection, I will not take the patient for an upfront surgery. So, I mean, this case was a borderline case, and so even in borderline cases, when I'm doubtful, I don't think, I mean, I completely agree that, you know, if you have a EGFR mutation, but it's borderline operable, and I'm not going to get an R0 resection, or I may be R1, it's better to err on the side of giving neoadjuvant and then, you know, taking it, rather than having a positive margin. We know that once margin is positive, radiotherapy is not going to help this patient. Might as well, it's just like, you know, I cannot say I will give an R plus and then ask my colleague to cure it. No, it's not right.
just go move one step ahead. Even if it is resectable, slowly we will start saying that we should be giving something more. Okay, that was a wonderful session. Thank you everybody.